That boy needs therapy.
Lie down on the couch.
Frontier Psychiatry.
Hi, it's Joel with the Taproot Therapy Collective podcast, and today I sat down with Dr. James Lynch and talked to him about the surgical intervention for trauma. You heard me right, surgery, not therapy, where the subcortical brain is regulated through injecting an anesthetic into the ganglia. He's the doctor, not me, so I'll let him take that away. But this is, if you want to look it up, a process called the stellate ganglion block that we're talking about, which can help patients of PTSD and trauma disorders learn to regulate emotion and control the symptoms of that disorder.
Here with Dr. Lynch, and he's going to tell us about the stellate ganglion process, which is like a surgical intervention for trauma and some other things too, but we're kind of interested in its application for trauma here. And it probably would be funniest if I just explain how I think that it works as a non-neurosurgeon, and then you can tell me, you can correct where I'm wrong. But
you're welcome to do that. Sure. Go ahead, Joel. Thanks for having me.
Yeah. So the ganglia, like, the base of the brain, you start to have the brain turning into the brainstem and connecting to the body. And a lot of that is where trauma responses are stored. So if you drill in between like the C6 and C7 vertebrae and inject anesthesia into those roots of how the body has learned to physically hold emotion and trauma, then it relaxes them and makes them be reprogrammed. Is that right?
Yeah, I love that you gave me that to start off with. So this may be helpful, and then stop me if I ramble, because I think in my experience, I've been doing stellate ganglion block now for over 10 years. As an adjunct to trauma-focused therapy, it's been very helpful in patients with severe anxiety as well. Pardon me. But it's one of my favorite things to talk about, because when you hear about what it is that we're doing and why, it just makes total sense. And the fact that we hadn't figured this out much longer ago is a little bit puzzling. So the first thing is the stellate ganglion block. It's a very, very simple procedure. It's an ultrasound guided procedure that's done without a whole lot of fanfare, frankly. It's been around for 100 years. So when people hear that, they're usually fascinated that, hang on a second, this is not something new. No, not at all. It's been around since the 1920s. What's new is the application of using this procedure that's been around for quite some time as a procedure used in pain medicine primarily. The new part, when I say new, I mean really in the past 10 to 12 years, it's been applied to treating essentially an overstimulated sympathetic nervous system. And that's exactly what it is. So the stellate ganglion block really refers to a nerve block using simple local anesthetic. So, and I'm only laughing because you did use the word drill. So I just want to reassure everyone, honestly, there's no drilling involved. And the procedure takes literally a few minutes with a needle about the size of like a COVID shot or a flu shot. And most people don't describe it as painful at all. They say it feels a little bit weird. And when it's over, most people just say, that's it. That's all there is to it. Again, and I think we're doing this on video, but the procedure was performed 100 years ago by just touching next to the neck. There's a bone here at the C6 vertebrae, and then injecting along your finger a local anesthetic. And that had been done like that for many, many years, way before the advent of ultrasound technology or fluoroscopy on thousands of people for pain conditions very successfully with very few risks. So about 12 years ago or so, a few of us, myself and my partner, Dr. Sean Mulvaney, who are the two founders here at the Stellate Institute in Annapolis, Maryland, really started adopting this and researching it in the military. And that's really where both of our roots go, although both of us are now since retired from the U.S. Army. But we take care of trauma survivors from all backgrounds. Initially, what we ran into was primarily combat-related trauma, based on the population of people we served with. But we have since learned over time that in no way is the only type of trauma background that the stellate ganglion block can be helpful for. But just to give you that again, over 10 years ago when we discovered this, there was a report, kind of a random report in the literature of someone that was shot at a close range and had severe pain from gunshot wounds to the shoulder was treated with this procedure for pain, the stellate ganglion block. At that time, this was a young woman who had severe PTSD developed from this assault, as could be imagined, but was completely unable to participate in therapy because of the amount of pain or distress, psychological pain that she was having, that she couldn't even go in the door to the psychotherapist. Meanwhile, she was debilitated with her trauma, her traumatic injury. After the stellate ganglion block series she received, her mood changed dramatically, and she became much more willing to engage in psychotherapy as her anxiety symptoms were dialed down. So that's really what started. But what the heck is the stellate ganglion block doing then if we're not drilling holes in anything? We're literally placing a numbing medicine called ropivacaine alongside a nerve in the neck. But for it to make sense, you have to understand what the nerve is. So a lot of people who are in this area understand polyvagal theory and understand the vagus nerve, which controls the parasympathetic nervous system. And it lies also in the neck, both sides of the neck, within the carotid sheath. Just outside of the carotid sheath in the neck is a nerve called the cervical sympathetic chain or cervical sympathetic trunk. And this is the easiest way I describe it to my patients or other people when I'm first describing it. So I hope this will make sense. But there are areas within the brain where the body stores threat responses. Many of your listeners know this and understand, whether it's the amygdala, the prefrontal cortex. There are several connections within the brain where fear and threat centers and memories are stored. There's also several areas in the body that regulate or that feel the effects of the sympathetic nervous system. So for the obvious ones, like the heart, the lungs, the muscles, the sweat glands, all these things are connected through a series of connections in the body, a series of connections in the brain, and all of them come together in a simple single nerve in the neck called the cervical sympathetic trunk. That's the only thing that nerve does, is it carries signals in two directions, body to brain, brain to body, and that's it. And that nerve essentially can become dysfunctional in some people. And by that, I mean...
Is that from an environmental thing, like a trauma happens and then that stores some information about how to communicate with the body in a way that isn't helpful?
Yeah, I think so. I think
response gets stuck.
It's what's interesting is what it takes to get that nerve to stop working properly could be anything. So for some people, it's a single traumatic event that traumatic experience can be enough to take what's essentially a circuit, right? Because it's going through. So we're talking brain to body, body to brain. If there is something that conditions then a fear or a threat response in the brain, it then automatically triggers the body to respond a certain way. So you can imagine then if there's some insult, I'll just say, or some experience that causes that cycle to become dysfunctional, where it's all of a sudden now feeding back on each other, you can end up with a sympathetic nervous system that's inappropriately elevated or inappropriately stimulated. That becomes the issue that we're targeting with this particular procedure. It's the thing that...
I just was going to say, I think that's where the cognitive therapy breaks down, is where that response that's causing panic is coming from the body, and we're trying to control it totally mind over matter. But there's a negative feedback loop where my body is agitated, so my brain is stressed. Now my brain is stressed, it's making my body more agitated. And leaving the body out of it doesn't treat the trauma a lot of the time.
No, I think that's the point too. And something that's probably worth noting right now is I never have and never do consider the stellate ganglion block some standalone therapy. And you may run across some providers that'll say, I'll do this procedure and this will cure your anxiety or cure your PTSD or something like that. That's not really the case. And some people might say that. What I believe is what can happen is this dysfunctional connection between the brain and the body becomes a barrier to allowing you it just won't let you past it. And what hundreds of my patients over the past 10 years have described is going to therapy and just not being able to break through. Or more importantly, I think, are the therapists I've worked with over the years who say, I just can't make the progress in therapy because the person is my client is just not calm enough in their body to make the gains that I need to do. Or what would normally take 3 years in therapy following the stellate ganglion block can now take, 3 to 6 months or something, because we have now taken essentially these two areas of the sympathetic nervous system and uncoupled them.
They can relearn how to talk.
Yeah, and then so that's an interesting point, because for many people, the effects of the stellate ganglion block are immediate, meaning within minutes, just in the exam room. The way the procedure is done is in an outpatient clinic. You don't have to go to a hospital or be in a fancy surgical suite done under fluoroscopy. In fact, it's done quite more safely under bedside ultrasound, and that's something that we do here at the Stellate Institute, every day. Just someone lying on a patient exam table under ultrasound guidance, locating all the critical anatomy in the neck, and then really a simple ultrasound guided injection with a tiny little needle that most people feel very little at all. They say it feels a little bit weird. And then within recovery, within a few minutes in the recovery stage, people will notice things, and many will actually report a physiologic release of something. And it's interesting because a lot of times it's hard to verbalize, but it's not uncommon at all for people to get quite emotional. Even people who haven't cried in many, many years may sometimes feel emotions well up or feel a release of some type of tension.
That's what I was going to ask, is because we use, I'm not a practitioner of the physical therapy, but we work with ones that have a ROI sign so we can talk and they kind of feed back into each other. But Rolf massage or myofascial release, where it's not a fun massage that's rubbing the sore place, but you're kind of trying to rip the fascia and make the body unlearn how to hold an emotion. Those, after there's significant progress, people just have an emotional flooding of older stuff that's now leaving. Brain spotting, same thing. I mean, my experience was I'd been in 5 different kinds of therapy. They did different things, but then 30 minutes of looking at a pointer with brain spotting, I felt this thing under my life in my body that I had been trying to turn off my whole life, that I had not ever looked at that closely consciously, and then I could not turn it off. And there was 2 or 3 days of real raw emotional stuff, and then it was out. So I was wondering, when you hit that, does that start to, what's the next couple days look like? Does creativity come back online, or is there more of an intuitive? I mean, do you notice patterns in what people report?
Yeah, that's a great question. So there's 2 things, I guess, in terms of the science behind the symptoms that people have reported. These are things we've published in peer-reviewed literature that can be found on the website. The actual symptoms, using DSM-5 criteria for things. Those things are on there. The thing that's not, I think, is when you sit in the room with somebody after the procedure, and we just have some quiet music playing, and I sit in there and I just allow people to relax. And I tell, sometimes I'm not a therapist, so I don't pretend to be a therapist, but I'll just encourage people to let their brains go. If they've been trained in relaxation techniques, I help, reinforce that that's a good time to do that, whether it's belly breathing or other things. And then the themes that people will report are actually quite interesting just that day. And the words that people will use to describe the feeling after a stellate ganglion block are things like light or calm or more clear. Many people describe they feel instant and immediate calm, and their muscles relax, and some type of a calm come over their entire body. So a physiologic thing as well as that mental thing. People also note a clarity of thinking. That one still intrigues me, but people will use different words to describe it, as if the swirling thoughts in their heads have now calmed down, or they can now just concentrate and think on one topic without balls bouncing around inside their head. And these are kind of immediate things that people describe. What I think over the course of the next few days that many have reported back to me is the things that would normally upset you might still be there. And I think this is important because it reinforces the point that this procedure is not a magic wand, and it could be anything, right? It could be the slow driver in the left lane. It could be, your kid dropping a plate and a loud noise or something. Those things will probably still bother you. But what the block may do is uncouple that immediate and automatic response that you couldn't control before, so that you would always just go 0 to 60 if something happened and you had no control over that. It was completely reflexive for you.
And that emotional response is happening before thought, even. It's happening before conscious language-based prefrontal cortex thought. So it's not something that you can sit and have insight into to make it go away.
No, and I think that's, to your question, I think that's the thing that's interesting, is people will then feel armed and able to actually deflect that. which is interesting. And that people use different words to describe that. Like I got a little bit of headspace. I got a little bit of leg room back. I got just enough time where I don't have to fly off the handle. And so I'll realize this is something that would really upset me previously, but I seem to be fine right now. And those could be other things like just being in a public place, or, the example comes up all the time of, going to a restaurant and maybe not having to have your back to the wall now, or a loud noise, you maybe don't respond the same way. So I look at it as something that allows the automatic uncoupling of the body and the brain through the sympathetic nervous system. I do think that people that have had deep-seated issues for long periods of time, there's also an unlearning effect that happens. And I think you said something earlier that made me think of that. Some people do very, very well automatically feeling much better. And to give that a number, what we typically see is a 50% decrease in symptoms using whether it's a GAD-7 or PCL-5 type score, 50% drop in symptoms. Some people feel so good that they feel uncomfortable. And I think that that's worth noting. There are some people are just, oh my God, I haven't felt this good in so long. It feels weird. And then that's where they work with their therapist to kind of get it used to this new period or new phase of kind of unlearning some of the.
Well, that safety response of if I'm feeling good, then that's bad because it's going to be taken away. As soon as I'm feeling good, I'm going to be punished, that you get in some trauma. When the body symptoms calm down, there's probably a more conscious panic response of, oh no, this is bad. I'm not allowed to feel like that.
Yeah, and I think that's a good point. And I think that's really one of the key things is, for me, not a therapist who does the procedure, it's always important to me that I reinforce, hey, we should try to tee this up so that you have an appointment with your therapist within the week or so afterwards. And I think that's critical. It allows people to just, do this as a team, not just, some doctor somewhere off in Maryland is doing his own thing. So I really welcome that. And I find that a critical component is if I'm working with new therapists that are not familiar with the block, I'm happy to take a phone call or an email or something just to work through like, okay, what's a good way to do this as a team.
Yeah, the integrative approach is so important. I mean, and that's one of the things that we work with. I mean, 90% of the calls that we get, we're never going to see those people's patients, but we make sure that they're going to get what they need. We don't provide ketamine. We don't provide medication. We don't provide neurostim. We don't provide stellate ganglion blocking. We don't provide different kinds of massage. I mean, one day maybe I'd like to, but with the massage and some other things. But we're able to figure out what you need. Do you need one or two? If you're going to do brain spotting, let's get you with a Rolf massage person. If ketamine or neurostim or stellate ganglion is better. I mean, the podcast is helpful because we can just send the interview with the provider to the person and they're hearing it. I'm not just giving my impression badly of what I remember.
Yeah.
But the issue we've run into with stellate ganglion is just that people do it here, but they won't do it for trauma. They want to do it for fibromyalgia and pain, phantom pain disorders, but they won't screen the patient and see them for trauma. They don't have a protocol for that or use it.
Yeah. Yeah, it's too bad. So that's probably one of the most important things to say about the whole topic for anyone who's listening to this that's saying, hey, this sounds like a pretty good deal. Why haven't I heard of this before? There's a complicated answer to that question, but certainly one of the barriers is the fact that insurance does not pay for this procedure for behavioral health issues. And it's a significant barrier. Yeah, depending on where you look around the country, a lot of people charge somewhere around $3,000 for the procedure. At our clinic here in Annapolis, Maryland, which is right outside Baltimore and DC, we charge $1,200, and we both myself and my partner, Dr. Mulvaney, were the probably fair to say the if not the two of the most experienced in the procedure in the world. We're the ones that have published most of the original research on this over the past 10 years. And when I retired from the Army, I came here specifically to join up with him so that we could form a center of excellence. Having said all that, we try to make the procedure within reach. And I think a $1,200 procedure is not within reach of many, many people. It isn't. That's fair. And
that's a better price than we've seen anywhere, though. I mean, I was seeing $3,000 and $4,000 when I was looking at different places.
Yeah, you'll see that amount of money, and I think other providers will do it under fluoroscopy in an OR suite. Some will use sedation, which we do not do here, nor do we believe that that's necessary. In fact, believe that has harm associated with it. So we don't. And like I said, we've done more than anybody else, and we we spend a lot of time with our patients is the other thing. I think most places you go and you get a procedure, doc talks to you for a couple of minutes, and I like to spend, close to an hour with my patients when they come, because I think if you're going to come and have some provider do a procedure like this, like you want to get their experience. You want to hear from them. You want an opportunity to ask questions. You want to, I don't think, at least that's what I think.
Spending an hour with a doctor is not common. I mean, your psychiatrist sees you for 3 minutes and writes a script when they hear anxiety 3 times, and
so
it's not their fault all the time. I mean, the industry, realities in the industry that are not good, forced changes in doctors and providers that weren't, it's not always their fault.
Yeah, no, I think you're right, Joel. And when you're limited to insurance and all the wickets that happen like that, you're kind of shoved into a hole. So until insurance covers this, we'll continue to do what we're doing. And then I guess the silver lining of that is we can take as much time as we'd like and provide the type of personalized care as we can without someone, whipping us like the rest of the medical community for right now. So I guess that's
can people push the AMA and the APA to try and force insurance providers to cover it, to say that this is what's needed? I mean, there's this view that, you have cognitive therapy and CBT just take over in the 80s and the 90s. And a lot of it's a reaction to, psychoanalysis takes 20 years. We don't want to pay for that. We want something faster. But I mean, you do have this attitude that, well, the body's a go-kart that carries the brain around. If your body's sick, go to the doctor. If your brain is sick, go to the therapist or the psychiatrist. And that just isn't how it works. I mean, the neuroscience we have now is like it's in the interplay between those things and the emotion and the cognitive. So, I mean, how fast do you see that changing, and what's the best way to kind of lobby this unhealthy system to be different?
Yeah, I love it. I spent, so in the 10 years or so that I've been doing the procedure, so I'm a full-time clinician, I'm seeing patients all day, every day. We are still conducting research because we believe, Dr. Mulvaney and I both believe, that if you're going to be relevant, you got to keep studying what you're doing, keep making it better. So we're currently doing a randomized control trial with Ohio State University right now that we're paired with for a study that we're currently doing. We got more, in the chute. And then really the advocacy piece has been a major piece for me. Went earlier on when I was in the military, the advocacy was designed for military, active duty military, and the veteran population. And it's been, pushing a rock uphill for 10 years, frankly. It's just trying to change large organizations, what's available, what's covered. But I think we made some gains within that community. So there are VA hospitals who will offer the stellate ganglion block at no cost to veterans. There's just not that many of them. They're kind of sprinkled around the country. They have kind of mixed experience levels, and it comes up a lot. So we do take care of veterans and military who don't have access to those. Will come to see us as well. But to me, the now that I've been focused a lot on the other 8 million trauma survivors in the U.S. is how do we get that offered across the board? And I just think, to answer your question, how do we best do it? I think what you're doing right now, spreading the word, raising awareness with a podcast is helpful. I think that patients that may have influence, talking to the right people might help. I just am a little jaded at this point that it's just a glacial process.
Yeah.
Although it doesn't make any sense to me that a procedure that's been safely performed for 100 years, that costs very little money and is very safe when performed by the right people and has an immediate impact, why that wouldn't be covered compared to all the other things that insurance pays for, that doesn't make any sense. It's just, I'll just keep pushing the advocacy and awareness piece, and hopefully the right people will catch attention to get the reimbursement piece caught up to us.
Well, and I think it is more of a philosophical fear maybe than even a practical one, that there's that if you start to rethink about medicine in this way, that the environment is a bigger variable, then how do you research it? Because there's too many variables and it's too big, and we want something where we can get it small and research it easy. But then also you're saying that medicine needs to be more integrative than it is. And that, I think that's a threat to a lot of different parts of the current system.
Yeah, it is. It's also just not what people are accustomed to. I'm learning in my practice in North Carolina. I had an office. I had right outside my office 2 psychologists and a social worker, and we talked regularly. And that's not the case where I am now in Maryland. So I've made efforts to try to build those type of relationships and bridges with community providers around the state. But it's definitely not what people are accustomed to or what we're used to doing. So, but I don't care. We'll keep trying to do that. And I think people like it. I think that clinicians who want to take care of people, I think more and more are starting to see that, hey, this is okay. Teamwork's okay. I don't have to have all the answers myself. It's okay to reach across the aisle and ask someone from a different discipline to weigh in on stuff. And that's my hope, at least, is that will hit a tipping point at some point, and people will become much more comfortable with reaching outside their discipline to do something that maybe they weren't trained of in their training, but it's the kind of thing that they realize now there's plenty of evidence to support it.
Mm-hmm. Well, I want to be respectful of your time. I know you need to hop off. I guess to close, we'll link to the website and everything so people can find you and your research. But I mean, if somebody's sitting there with trauma and they're trying to decide between ketamine, which is IV ketamine is expensive and not covered by insurance, Stellate Ganglion, neurostim is expensive and not covered by insurance. Brain spotting, if the provider knows a lot and has a bunch of the somatic training, then they're probably expensive. That's the cheapest option, but it's still an investment. I mean, where do I start? What do I do if I'm looking at these new exciting things?
It's a good question. I think so. To answer this part, if you're interested in stellate ganglion block and you just have a lot more questions, for sure look at our website, which I think you'll probably post up on a graphic, I guess, but it's thestellateinstitute.com, all one word .com. On it there's a whole slew of testimonials that I think are helpful for the personal story, but there's also full text journal articles of all the research that we publish on the evidence tab. And then on the FAQ page, we try to answer literally all the frequently asked questions we get. And then there's videos in there too. And they're all on YouTube as well. But the videos are to answer questions that are a little bit more, sophisticated, that you can't answer in a little 3-line sentence. So I would encourage people to do their homework, because I think it matters. And I think if it sounds like the right thing for you. If you're a therapist looking at your client saying, hey, I think this person could really benefit from this, and then coming back to see me in therapy, hopefully a lot of the answers to your questions are on that website. As far as how to get scheduled, at our place, we take either 2 things. Some people will refer themselves, which is fine in terms of access, preferably if there's a therapist who has a client to refer. I would love to do that, receive that from you. And we have a simple referral form that's on our website as well. If you scroll through the instructions, there's a hyperlink to a simple form. When in doubt, old school is fine with me, and I'm happy to take an email or a phone call with, hey, how do I make this work? But to try to answer all those questions, we loaded it all up in kind of a contact us piece on our website to answer those things. As far as trying to decide which other modality to do, that's the $1 million question. And I have people come that have tried everything, or they're in the process of trying everything. The only advice I'd have is if you're methodical about that, what can I try now to see if it makes a difference, and then give it a little bit of time so you're not stacking things up together. And I have some people that will come and they say, well, I'm in the middle of a ketamine treatment, I'm doing this, I'm adding this. And I think that's okay. Like, I'm happy to help you, but I think when you get better, you're going to want to know which one it was that really helped. Although having said that, sometimes it just turns out to be a whole slew of things or a combination of things. So I wish I could give a better answer to that, because I think that's the big question. And part of the research that we're doing right now is to try to answer that question, which is we feel fairly comfortable still getting the block works. Okay, got it. Now, what does it work best with? How do we combine it with certain things? So I think that's the next phase of what we're doing in research-wise.
Well, it was fascinating, and I don't want to make you run late, but I really appreciate your time. And hopefully, and maybe if there's questions or something, we can do a part 2. I don't know how much. We'll see where it goes, but I really appreciate it. Thank you so much.
Okay. Joel, appreciate your interest, and thanks for what you do.
Yeah, thank you.
All right, so that was our interview with Dr. James Lynch. If you want to check out more information on him, you can go to his website, which is drjameslynch, LYNCH.com. Again, that's drjameslynch.com. And thank you for listening.